You've been looking at a phase 1 study. You've been looking at combining molecular drugs together with immune checkpoint inhibition. Can you tell me what it is that you've been doing in this new study that you've got here with PD-L1 blockade?
Right. In previous years, we've established the benefit of BRAF inhibitor monotherapy, BRAF-MEK combination therapy for the patients who harbor an activating BRAF mutation with metastatic melanoma. And we've been performing studies in patient tumor specimens over the years documenting immunologic effects of those treatments, pointing towards, but not fully proving, but pointing towards the possibility that adding an immune agent, a drug designed to liberate immune function, if you will, which the PD-L1 blocking antibodies are amongst the class of such drugs, that adding those drugs might leverage some of the effects that are otherwise achieved even just with the so-called molecularly targeted drugs. So in this trial, the first goal in melanoma patients only is to establish safety of the combination. And we're actually looking at two different combinations. For patients with a BRAF mutation, we administer the BRAF inhibitor, the MEK inhibitor, and a PD-L1 antibody. In patients who lack a BRAF mutation, which include those who harbor NRAS mutations, NF1 mutations, and others as yet somewhat undefined in terms of their quote-unquote oncogenic drivers, they also get a MEK inhibitor with PD-L1 but no BRAF. Now
you could use molecular drugs, targeted agents like dabrafenib, to add to regular immune checkpoint inhibitors, PD-1 targeting drugs or CTLA-4 drugs. So why did you go for PD-L1 targeted agents?
Yeah, if you look at the available evidence, and in clinical practice we see the same, that CTLA-4 blocking antibodies promote the greatest wave of autoimmune toxicity. So have the highest rate of overall and severe autoimmune toxicity. PD-1 antibodies less so, and yet they have a higher response rate in melanoma, which is an interesting dual observation. PD-L1 antibodies were theorized and clinically appear to have comparable efficacy to PD-1 blocking antibodies, but less autoimmune toxicity risk. And the available evidence has been generated not in head-to-head trials of PD-1 versus PD-L1, but with hundreds of patients treated in comparable trials, in cross-trial comparisons. One can see that lower rate of autoimmune toxicity and overall toxicity. So if one were to simply enter this realm of combination molecularly targeted immune therapy with a perspective of wanting to have a priori the agents with the lowest overall risk profile of any type of toxicity, these PD-L1 antibodies are currently the most attractive.
Right, so what's happening then in your phase 1 study?
So far we've observed, as predicted, that we're able to give the drugs in combination at their so-called full doses. In other words, at their individual doses. Dabrafenib, trametinib, as a doublet, are able to be given at their full doses and are in the US approved for regulatory purposes and clinical practice. The MEK inhibitor has its own standalone dose, and each of those full doses are able to be combined with the quote-unquote standard or full dose of the PD-L1 antibody that's been evaluated in hundreds and hundreds of patients as monotherapy, so has a fairly firm understanding in place in terms of what the so-called recommended phase 2 dose is. So we've already established that we can give full doses safely, and having treated enough patients, more than 20 in each of the combination arms at full dose, we've seen in fact that the toxicity profile doesn't seem to be in any way suggesting synergistic toxicity. At worst, we have just each agent contributing their own, or so-called additive toxicity, which I think already points to the ability to then proceed to more dedicated efficacy studies, as well as ongoing molecular or mechanistic studies to understand, are these drugs really doing something together that they can't do alone in terms of immunologic effects.
Right, so what sort of efficacy signal, if any, is coming out of this study so far?
So really the primary efficacy hypothesis is that we will extend duration of response for either comparing to molecular targeted therapy alone or the PD-L1 antibody alone. And that's where we're in a luxurious position in the field where the average duration of efficacy, be it objective response or even stabilization, is reasonably long with these therapies, which is to say patients who respond typically maintain response for about a year's time on molecularly targeted therapy, up to 18 and 24 months on PD-1, PD-L1 blocking antibodies, including this agent. And so when you're then asking the question of whether you're able to produce more durable effects, at present we have about 1 year follow-up on the patients who were treated in the early portion of this study, but we may need substantially longer follow-up times to have a sense of whether we're able to maintain those remissions. So the early evidence is that yes, we're able to achieve responses as we would have predicted. Now the issue is, can we maintain them longer than we would otherwise?
Of course, initially, drugs like ipilimumab were giving a tail that was quite promising, and then it seemed that the targeted agents might not be giving the same tail. Are you saying you could extend that tail of the curve?
Yeah, well, in fact, you're right that a few years ago there was a sense that molecular targeted therapies didn't produce a tail, but in fact 3-year, 4-year follow-up data now from some of the larger studies from years past actually shows a tail, even in patients who've never gone on to receive immune therapy or other treatments. So, in fact, we have a sense that a tail exists with both approaches, an important point, because if either molecular targeted therapy or immune therapy can produce a tail on their own, when we think about developing these combination strategies, we'd like not to give them to patients who would otherwise do perfectly well on the available treatments. And so that's an important sidebar, which is a maintained focus on predictive biomarkers that would designate who those patients are.
Well, obviously this is a moving field, rapidly moving field, and a very fascinating one. So what's the message right now, the clinical message coming out of this for doctors?
Yeah, well, I think, simply put, sequential therapy with molecularly targeted treatment and immunotherapy as separate therapies, given until they're no longer effective, that's the standard. And as these drugs are approved and utilized in practice, I wouldn't want to suggest that there's any basis for throwing them together now. Even in a patient who has a high burden of disease that's symptomatic, where one would like to be able to essentially throw all therapies at the situation to try to gain control and ideally maintain control thereafter, while those motivations are understandable, the fact is we haven't firmly ruled out antagonism of these therapies at this early date. In other words, is it possible that by putting the drugs together you'd actually get less than an additive effect of the treatments? It is only with more time, more patients, and more follow-up that we'll be comfortable that that's not the case. And so I would say in these early days, this is not ready for clinical adoption at the moment, but we do have a green light from the early safety signals to proceed now into full-scale efficacy-focused investigations, which is where we're transitioning now.
So you can consider adding in PD-L1 blockade?
Exactly.